There, everyone. We are so happy to have you, whether you are joining us here today or watching later from the Cure GABA-A YouTube channel. We ask that you please mute your mics if you have not done so already, and include any questions that you might have in the chat box below. We'll have time to answer those questions at the end of the presentation. My name is Monica Joanna Alnakabe, and I'm the founder and CEO of Cure GABA-A, a nonprofit organization with the sole focus to develop potential therapies for GABA-A variants. By partnering with world-renowned researchers in GABA-A and the Organization of Patients for Clinical Trials. Today, we welcome Dr. Pam McDonnell and Laina Lusk. Dr. Pam McDonnell is a dedicated pediatric neurologist within the Division of Neurology at Children's Hospital of Philadelphia, known to us patients as CHOP. She specializes in epilepsy care for children. Her passion lies in exploring the epilepsy, envisioning a future where tailored treatments based on genetic insights could transform patient outcomes. As a member of the Epilepsy Neurogenetics Initiative at CHOP, Dr. McDonnell focuses on evaluating children with neurodevelopmental disorders, particularly those with pathogenic variants in the GABA transporter, the SLC6A1 gene, and collaborating closely with our sister group, SL6A1 Connect. Laina Lusk's research interest lies in unraveling the genetic mechanisms and clinical phenotypes associated with childhood epilepsy and related neurodevelopmental disorders. Armed with a Bachelor of Science degree in neuroscience from Bucknell University and a Master of Medical Science in Human Genetics and Genetic Counseling from Emory University, she brings a wealth of knowledge to her role. Laina has prior clinical experience as a cancer genetic counselor and a background in neurodevelopmental disorders research. She plays a crucial role in the Helbig lab, where she acts as a clinical liaison and actively contributes to phenotyping projects, furthering our understanding of these complex conditions. I'm handing it off to you. Please give us an introduction to the basic genetic concepts for GABA-A variants.
So thank you, Monica, for having us. Laina, as Monica mentioned, is going to go into the basics of genetics. I'm only going to touch very briefly on what GABA is, which stands for gamma-aminobutyric acid, which now you know why we call it GABA, is the most abundant inhibitory neurotransmitter in the brain. Brain is made up of lots of brain cells called neurons, and the way they communicate is through electricity. And the way that electricity can happen is by using different chemicals in the brain. There are three major receptors for GABA in the brain, and the one we're talking about today is GABA type A. And these receptor subunits are combined as heteropentamers, so there's 5 subunits. And you will see when Laina goes through her presentation, she's really going to break this down nicely with really cool pictures. But the more frequent ones are using 2 alpha, 2 beta, and 1 gamma subunit. And that's where you'll see in a minute we get a lot of the different A variant in different genes. And that's because they're encoding a lot of different parts of this receptor that we are talking about. And so this is just to give you a sense of where we are. This is a little outdated at this point in 2016, but I just like to show here. The first time anyone even discovered a genetic gene was the mid-90s, which now it seems like a really long time ago, but when I was in training, it really wasn't that long ago. And that's our TRNF4 gene. And then you can sodium and potassium channels were really the first one. SCN1A is one of our more famous genetic disorders, also called Dravet. And then you can see here the first 2 GABA-A genes are really coming in the 2000s. So again, not that long ago, and only 2 of them, the GABA-G2 and the GABA-1. And then again in the 2010s, we really got a jump, and now there's been a lot more added towards the end of this. But you can see here the next GABA genes that we were looking at, the GABA receptor genes, are right here. So already, even after 2010, we're looking at GABA-1 and GABA-B3 a lot, and we're learning a lot very fast. But also, we still have a lot to learn, I think. Here, I just listed all the different GABA-A variants. And the reason I wanted to bring your attention to this is because these are new genes. A lot of them have been discovered even after 2010, 2015. And so, we just started 2024. And so the way I like to think of these genes is that they're really part of a spectrum, and we'll go into what that spectrum is, but we are not necessarily picking each out individually and saying, here's your specific for this, here's your specific for that, which in my mind, that's not a bad thing. It really opens up collaboration. It allows us to use more medicines, and it just really expands our ability to kind of group the different genes and work on them together and just gather more data, have more people working on it, and have more tools in our toolbox, if you will. The clinical spectrum is really around childhood epilepsy with or without an intellectual disability and other neurologic symptoms. And it is rare to not have epilepsy associated with these genetic disorders, but it has been reported. And those patients have a neurodevelopmental clinical picture that does not come with seizures. So in doing a little bit of research and just kind of seeing what's been out there, there was a paper that came out in 2022, which I really liked. It looked at these particular genes, GABA-A1, GABA-B2, GABA-B3, and GABA-G2. What they showed was that you didn't need to do a paper for each one, and you can really gather all the information together. And they came out with 3 broad buckets of epilepsies that we're seeing. One of them they called epilepsy associated with fever sensibility. I would say the word I would like to use is more fever sensitivity. And that's going to be your spectrum of GEFS plus, which is your genetic epilepsy with febrile seizures plus. The reason they call it plus is because febrile seizures are typically only seen from 6 months to 6 years of age at the latest. And so what we end up seeing in children that have this spectrum is that they end up having febrile seizures past the age of 6, or they have some seizures outside of fever, or maybe triggered by illness without a fever, or even just unprovoked seizures. And then the more severe end of the spectrum being Dravet syndrome, which, as I mentioned, the typical Dravet syndrome is associated with a different gene called SCN1A. But Dravet syndrome, at the end of the day, is a clinical diagnosis that we do based on sensitivity to fever, the types of seizures that present, and some other developmental findings that are very classic. Test question would be a child between 6 and 12 months that had normal development, went in for vaccines, or had a fever and related to the vaccines, or just any illness, and then developed one-sided shaking, prolonged seizure, and then family noticed that every time with fevers they're having long seizures, and then around 2 years of age their development stalls, regresses, or just makes slow progress, and new different seizure types develop. And so that's the clinical picture. And what we know now is that SCN1A is not the only gene that can lead to Dravet syndrome, and more specifically, some GABA genes have been reported, but even then there are other genes that we're starting to learn more about. So that's the fever sensitivity spectrum. And GIFS Plus can have a variable spectrum. As a physician, as a parent, I know it's frustrating because you want exact answers, but as a physician, it's not a bad thing, because that means that we get to look at each child individually and not just say, oh, you are going to be this way. We're going to take each child, we're going to treat the child and support the child to do the best they can, and we're not going to hang on a diagnosis and limit what they can do. So for me, it's a really good thing. And so GEFS Plus can be anywhere from normal intellect to mild disabilities or learning difficulties to just a more severe neurodevelopmental disorder. The early developmental epileptic encephalopathy, unfortunately, that's the spectrum that's quite severe. And in this paper, they report, which is unusual, what are called homozygous variants that are very rare. And in general, we think of the GABA disorders at what we call autosomal dominant, meaning that you only need one change in the gene coming from either parent to have the disorder, as opposed to one change from each parent. And when you have the homozygous findings, which means one change from each parent, you end up with this early developmental epileptic encephalopathy that's a more severe presentation. But you can also get it from an autosomal dominant, meaning one change as well. And these are going to be your children that present really as infants very early on with very severe, hard to treat different seizure types, one of them being migrating focal seizures. So a seizure starts in one spot of the brain, but you can have them essentially starting from any part of the brain and shifting. And then really any early onset epileptic encephalopathy in the setting of a GABA-A variant that's considered pathogenic can explain. And in this case, these children have drug-resistant epilepsy as well as more severe neurodevelopmental disorders. And then we have our genetic generalized epilepsies, and these are also a very, very broad spectrum. Epilepsy with myoclonic atonic seizures, also known as Dosa syndrome or MAE, and that is the classic seizure type or the epilepsy type that's associated with SLC6A1, for example. And that's going to be your jerk, your seizures that are called myoclonic. Those are jerks. The atonic you can drop to the ground. But we do know that the GABA variants can lead to this type of seizures. You can have juvenile myoclonic epilepsy, and that's a seizure disorder that's seen in a lot of the times normal development, normal intelligence teenagers. They start, close to, like, I would say 12 to 16 years old, and they develop the seizure, this epilepsy that typically we think of it as relatively easy to treat with a medication. You can have atypical absence seizures only, which in that case, you would not fit criteria for the myoclonic atonic seizure type. And that's the absence seizures, which are brief staring spells. And really any type of generalized epilepsy that we see, I think you could have tonic-clonic seizures. And when we talk about, just to clarify, generalized versus focal seizures or epilepsy, we're talking about whether a seizure starts in the whole brain at one time or if it starts in one spot. And epilepsy is basically just the name of anyone that has a condition where you have one or more seizures, and typically you end up needing medication to treat them. So saying someone has epilepsy doesn't really tell you why they have it, what seizure types, or predict anything. When I explain it to patients, it's like saying you have pneumonia or lung infection, but I'm not telling you if it's bacterial or viral. Does it have treatment? What antibiotic do we use? And so I think of that as epilepsy too. It just tells me you have seizures. That's it. So I try to be very clear on what kind of epilepsy we're talking about and why you have it and what it means. So as a seizure specialist, I tend to focus on seizures a lot. It's something that's easy to measure. We have medications, but we also know that for families and patients, sometimes the seizures are not the most disabling symptoms that we see. And a lot of the times we study this a lot less. And so a lot of the outcomes and research that we do or the measures that we're using are based on seizure types and seizure outcomes. And so I just wanted to mention that developmental delay, which means there's delays in achieving milestones around up to age 5 years old. And then intellectual disability is sort of what we move on to once you are elementary school age children. And now we're thinking more of our cognitive abilities. And so you can have that broad spectrum I was talking about. And besides the neurodevelopmental disorders, you can have movement disorders, and that can present as ataxia, which is trouble with walking or balance problems, but you can have a number of other things related to movement disorders. Tics are, for example, considered a movement disorder. There's something called dystonia, where you get abnormal muscle contractions. And so those are treated a little bit different. It's important that you know that could be seen with these disorders because a lot of movement disorders look exactly like seizures, and they're really hard to separate. And although ideally we're catching these events on EEG, sometimes it's not possible to get people in. Sometimes children don't tolerate the EEG long enough to show what the movements are, and it can be really tricky. So really knowing that the movement disorders are part of the spectrum is very important. Visual impairment is also something that has been reported in different ways. Things like nystagmus, where you have the eyes kind of moving side to side, is something that could be seen. Your head circumference difference, so either too big or too small. And I think in this case, it's really important to know that they can be seen in these disorders, because sometimes we end up doing a lot more imaging than we need to. And what that means is that we are putting our children under anesthesia when you really potentially don't need to. And I know none of us want to give anesthesia to all children if we don't have to. And so we know, like, we had one brain MRI at the time of the onset, but then we have the genetic diagnosis, and we know that having a large or a small head circumference can be expected. We don't need to keep repeating MRIs to see what's going on. Behavioral disorders have been reported, and I include everything under this. For example, things like mood disorder, so anxiety, depression, but then also, of course, behavior problems. And then a lot of the papers don't particularly report separately on autism spectrum disorder, but whenever we say neurodevelopmental disorder, that can be under that umbrella as well. And so I know, Monica, you have worked with SLC6A1, and there's a lot of other genetic disorders out there, and you can see these symptoms really overlap with many of our different disorders, but the treatment, and, one day, as you mentioned in my goals, would be this, you get the patient and you get all the information you need, and you just develop this amazing treatment plan that's tailored to that person. But so in this case, if you have a Dravet syndrome clinical picture that is from a GABA variant, you really don't want to treat them the way you would treat a Dravet patient from SCN1A changes. And so knowing that the symptoms overlap, but also understanding we need to really be sure of what we're treating if we can, is really important. But you could see why when you present to your first neurologist, that a lot of the times we're not able to say, oh, definitely this is what we're seeing. So the takeaways from this particular paper, and just in general from my reading in the literature, is that none of the genes so far that we know, and I'm sure with time we'll learn a little bit more, are specifically associated with a single want presentation. And even sometimes within families and same variants, we can see different presentations, which probably tell us there's other genes at play that are interacting in the way that we are presenting each patient. And the one thing that they did report on was that if the variant is in the transmembrane, and I think this will make more sense when Laina does her presentation, is that you can see a more severe presentation in that case, but not all the time. So even then, just because you have a transmembrane location, it's not that you are definitely going to be more severe, but that's the one association they have seen. And more importantly to our patients, we know they, of course, want to know all the details, but at the end of the day, how does this translate to our medication? And so the good news, and for some people, maybe it's bad news that it's not as specific as we want them to be yet. The good news is that what we're seeing is that the seizure types and the type of epilepsy, whether you know what it's related or not, often are what is guiding treatment and what's working best. And what I mean by that, so if you present with absence seizures, regardless of why you have them, there's 3 medications that are going to be the top choice for any neurologist, whether they know anything about genetics or not. And that's going to be Depakote, which is the VPA there, the valproic acid, lamotrigine, and ethosuximide. And so they might try one of those 3. The good news is that it's not going to make things worse. Like with sometimes some types of variants, you might add a medication and make things worse. But it doesn't require that you have the medical knowledge of GABA variants. And so if you live in an area that is far away from academic centers or folks that have knowledge, at least in the beginning, when you're figuring out what's going on, likely you're going to end up with the right medication just based on the seizure type. So I hope this can bring a little bit of reassurance to folks. And so also depending on the seizure types you were having or the clinical presentation, whether it's the fever, sensitivity, seizure types, or our generalized epilepsies versus epileptic encephalopathy, we're looking at, clobazam, which is also called Onfi, and Depakote and ketogenic diet for the seizures with febrile sensitivity, and that is very true across the board for most of our patients. Lamotrigine, which is something we do avoid with Dravet syndrome related to SCN1A, actually works quite well for patients with GABA-A variants, and it's good for most seizure types. And then phenobarbital is a medication we use for really the neonatal period, and it does seem to work well. So again, if you're presenting with seizures like first week of life, you're going to probably receive phenobarbital, and it does seem to work well. So it is reassuring that at least with the medications that we have now, we are able to, within reason, unfortunately, sometimes drug-resistant epilepsies don't respond well to one medication or even 2 or 3, but we're all going to start as neurologists when we're looking at the seizure types, we're going to end up selecting the drugs that work best, just based on the knowledge of what seizure types respond to what. And I just wanted to briefly mention, and I don't know if Laina has that at the end of her slides, but we do have our Epilepsy Neurogenetics Initiative clinic. It's a multi-D clinic. You can see the building behind me is where you would be seeing us. We have a child neurologist, which is me. Some of us are both epilepsy and neurogenetic experts. Neurogenetic. So I do both. I can do second opinions for both the epilepsy management as well as the neurogenetic diagnosis. Counselor, and Laina is the genetic counselor I work with almost all the time, which is really nice because we're just a team with almost like one brain right now. And we also have the physical therapy, occupational therapy, the social worker, and a great research team on site. So you come in, you do one visit, and everything's being done together. And there's the email for anyone interested to reach out for second opinions. And we have an excellent administrative team as well that can, figure out a way if, how do you need referrals? How do we get you scheduled? What's your convenience? We do have a few other sites for our clinic that don't have the interdisciplinary aspect of it. It's just me and a genetic counselor or another neurologist and a genetic counselor. But sometimes those are closer to some other areas, and we can always start there and figure things out, especially if locally you have a really good team otherwise. And so I guess what we can do is just save questions for the end, and I'll let Laina take over.
And jump in. I'll talk first about an introduction to genes into these GABA-A receptors. So a gene is a section of our DNA. Our DNA is just a long string of letters that we have all throughout our body. And a gene is just one section of that DNA that codes for a protein. So the gene is like a recipe within a broader set of like recipe books. Chromosomes are the packages that DNA come in. So we all have 23 pairs of chromosomes. We get one full set from our mom and one full set from our dad. So again, chromosomes are just packages. DNA is sort of the substance that makes our genes. And the genes is usually the thing that we find most important because they code for proteins that our bodies use. Again, if you zoom into the gene itself, just a long string of letters there. In our case, there's lots of different genes that we're talking about. All of them start with that GABR, talking about this GABA receptor, and then there's A1, B3, G2, many different ones. And I'll kind of explain how they all work together. When we talk about genes, we can, and these changes in our genes, we're talking about changes that cause the protein to not come out and work the way that it should. So a mutation is just a way of saying a change. So a lot of times we use the term variant. That just means any kind of difference. And we care about the ones that actually harm how the protein works, because most changes in our DNA just make us different from other people and don't actually affect anything, don't change the protein. But the ones that we care about do. So what do these genes do? What do they actually code for? So they code for parts of a GABA receptor. A receptor is where certain chemical signals in the body can bind, and it's also function as an ion channel, which means it lets certain ions or these negatively charged particles flow into the cell. And that helps the way that the cells communicate with each other and how signals are passed through the brain. So it's a receptor for a couple different things, but mainly the signal GABA, which really just tells our neurons to slow down and tells our brains and bodies to slow down, and in several different ways. And then the channel itself is for these chloride ions. So I'll have a picture in just a minute. And then when we talk about all of these different genes that we talked about, they are all code for different subunits of this final protein that gets made. So all of these they're a part of the protein, they come together, and then they make that final GABA receptor. And again, the picture will make it more clear in just a moment, but that's why we see all these GABA-A's. They're all the different alpha subunits. GABA-B's are the beta subunits. GABA-G's are the gamma subunits. And then there's these couple others like delta, which is GABA-D, etc. They all combine together in different ways to make slightly different versions of this receptor. So you might use, GABA-A and GABA-B to B2, and then GABA-G3, and that makes one type. And maybe use a different number of for one of those, and it makes a slightly different version. There's these other subunits, the Rho subunits, which are the GABA-Rs. And these make a slightly different, an alternate type of this GABA-A receptor called GABA-A Rho. And that's a little bit different, but functions somewhat similarly. So again, this is just to give you a brief idea of why are there so many different things with really similar letters, but slight differences. It's all because they're slightly different versions of each other. And this is just a quick picture to show, and I put back in the context of all of our DNA and our chromosomes. These are where the different genes are scattered throughout. Some of them are close to each other, some of them are far apart. But again, all of the proteins come together in the end. So this is if we zoom into our brain and we look at the individual cells, which are the neurons, and then we zoom in even further to look at one neuron communicating with another, that's where we can see this GABA receptor. So we have, in blue, the originating neuron sending GABA out, and then in purple, our receptors receiving that and allowing the yellow chloride ions to pass through. So it makes this channel that can open or close based on other factors, including like whether GABA is attached or not. And then if we kind of were to flip this and look at kind of how this is structured, this is where all of our different components come together. So we have, in this case, 2 betas, 2 alphas, 1 gamma. They come together to make this receptor. There's different locations within all of these different parts of the protein affected that could change the ultimate symptoms that you're seeing. Membrane is where those channels are sitting. So if they can't attach to that, it can cause different problems. If they don't react to GABA, if they don't open or close properly, if it's in one subunit versus another, all of these different factors of where the specific change is and your final protein can affect the types of symptoms that you will ultimately see in the person. Again, and this is just real quick showing all the different combinations that can happen with all these different genes. And where they might be located. Again, just to give you a sense, some of these are kind of more important across the body. Some of them are more specific to certain types of cells. So we'll get in a little bit more to the types of variants that we can see. So again, a variant is just a change in a gene. It can be like a typo or a spelling change. Most gene changes are harmless, but some can cause problems. Harmful variants are the ones that, again, interrupt or change the final protein product. So in this case, our GABA receptor. If it's missing or abnormal, it can lead to changes in how the brain functions overall. And it's these changes in the brain and how it functions that leads to all of the features that we see. So I kind of just highlighted here, it's sort of like a change in a gene is sort of like a change in a recipe that leads to a change in the product that gets made, like our cake from the recipe. But then ultimately the symptoms we see might be in a broader context, like cakes being sold at a store and it's not selling as many cakes because the cakes aren't coming out correctly. So it can be sort of just a process going from gene change to symptom, but it's this network of things involved. So just a little introduction to some of these types of variants or changes we can see. One is called a missense variant. That's where we replace one of our components or building blocks of the final protein from one type to another. So in this case, you can see as we're sort of stringing along and making our final protein, in the top, there's one part that's TYR or tyrosine. Because we had one letter change, it gets converted into something called asparagine instead. So this can lead to some changes in that final protein. And this is what this can look like. So you'll see one set of letters, a number, and then another set of letters. This is saying like our expectation is at position 130. We would see one of these TYRs, the tyrosine, and instead it's ASN, or it changed to a different amino acid or a different component here. A nonsense variant is one that causes an early stop. to the whole protein. So we swap out that TYR instead for a complete stop. The rest of the protein doesn't get made. We don't add any other amino acids. So this can lead to that protein not being there at all if it's too small and it gets broken down. So a different type of change. It's not just swapping one thing, we're cutting off a whole section. And this is what this can look like. There'll be a star saying now there's a stop. Sometimes this will be an X instead. A frame shift variant is one where there's a single extra missing letter that changes how we're coding for things. So we use 3 DNA letters at a time to make one component that goes into the protein. So if we're missing a letter, we add an extra letter. That can shift the set of 3 that we're looking at. And so it can cause a whole long string of changed amino acids or changed components in our final protein. And usually it leads to it stopping early, and so it gets shorter than it's supposed to be. And this is how this will look. Similar to before, we see that we're expecting the TYR at position 130, but then in this case, it gets changed to MET or methionine, and then we indicate there's a frame shift with the FS, and then the star 11 means 11 amino acids or 11 components down, we will see a stop. You can also see things called splice site variants, which are just in terms of how we combine different sections of the DNA together, the different components to make the final protein. Sometimes you might use one section versus another. In this case, like including a yellow section and cutting out a green section. And if we have one of these things called a splice site variant, that's where we might include the green part instead of the yellow part. So these are less common types of genetic changes, but we can certainly see them. And they usually will look something like this, where there's a plus or minus number, and it's just giving us a specific letter change, because it's not changing those main components, the amino acid, it's changing like which set of amino acids we're actually including. Just a little bit different. And then we can have deletions and duplications. That's where you might have one section that's missing or one section that's put in twice. And this can include other genes. So sometimes this can look a little bit different in terms of final symptoms because more than one gene is affected. One other issue that we can see is something called mosaicism. That's where some cells in a person's body have a genetic change and some cells don't. So this can come up sometime after, a sperm and egg come together, that a change pops up. So a lot of times people that are mosaic, they only have a certain genetic change in only some of their cells. And so they might be more mild than others, but that's not always the case. It depends on where we see the change and where we don't. But this is just to give another little detail about how some of these changes end up working in our final protein. So we have our 5 different components that we combine together typically to make all our receptors. And so they all combine into, let me just zoom ahead, are receptors that can let the ions pass through. But what can happen if there's loss of function, like if a gene is missing or if it's really short and isn't getting made at all, can lead to something called loss of function. And that's where we can see only about half of the final channels getting made. So because in this case, half of the green is not there, only half of the channels are made and are working. Another type of change, one that's kind of rare overall, but something that can happen in these types of disorders, something called a dominant negative change. And that's specifically when we have those missense variants. If you remember from before, where one component gets swapped for another, it can cause one of these components in our final protein to be there and combine with the others, but not work correctly. And so this can lead to more than half of the channels that get made to not work correctly, because it's just by chance if you get, in this case, 2 of the green ones that work together with the blue ones, and you don't include any of the ones that are now in pink. So these types of changes are often more severe than the pure loss of function ones, because it's more than half that aren't working correctly. And as Dr. McDonnell mentioned, some of the ones that are autosomal recessive, which we'll talk about in just a moment, but that's where all of them would not be working correctly. Because it's sort of a doubling of the one we see here, where both of these copies are not being made at all. So you can't make any of the channel because you don't have any green components at all. And then so just kind of showing again, loss of function is most of those nonsense or frame shift changes, as well as most splice site changes. It does include some missense changes, and it includes whole gene deletions. Dominant negative is almost always a missense variant, but it's only some of them, and rarely it can be caused by other types of variants. So back into inheritance. So these can be inherited from a parent, or they can be de novo, which means brand new in a child. So they just occurred in a sperm or egg that wasn't seen in either parent. The more severe forms of this disorder are more likely to be de novo or brand new, or they could be autosomal recessive, where you inherit something from both parents. As Dr. McDonnell mentioned, this is more a rare version, and I'll show some pictures of this in just a moment. So autosomal dominant is where one parent has a change, they pass it on like a 50-50 chance, like a coin flip, every time they have a child. De novo means brand new, not seen in either parent, so it just randomly shows up in a child. From there, that child has a 50-50 chance of passing it on to their future children, but it's not something we would expect to see in their siblings or other distant family members. And then autosomal recessive is where one change alone isn't causing a disorder. So that particular change might be really mild, and so it doesn't really seem to have any effect on either parent. But then when they combine together, now a child might have a more severe disorder, because both changes are affecting them. They don't have any working copy of that particular gene. And then a person that only has one change, but then has a healthy copy and is therefore doesn't have the disorder, they would be called a carrier. So those people, again, have a chance of passing it on, but because they have one working copy at least, they don't have that disorder. So again, this is just a rare situation here. Most of them kind of fall more into this category here of de novo, but this is something you could potentially see. And then one other sort of rare situation that I just wanted to mention is something called parental mosaicism. So if you remember, we talked that mosaicism is when some cells have a change and some don't. If per se you had a parent that had some cells maybe in their eggs or their sperm that had a change, they could pass it on to a child where that was what they grew from. They had it in the egg or in the sperm from the time they were conceived, and so now it's throughout their body. But the parent themselves might not have a disorder at all, because they just have it in certain cells. The reason I mention this is because this is why we say if something does look de novo or brand new in a child, there's still a small chance that you could have another child with this disorder, just because of this phenomenon called parental mosaicism. All right, so then I'll pause there and we'll turn it over to questions.
We have a question in the chat about, do you know which type of change leads to neurodevelopmental disorders such as autism? And no, we don't. I mean, the only hint that we have right now is the transmembrane change variants that can lead to a little bit of a more severe or moderate to severe clinical picture. But even then, it does not mean that that's what you're going to see. And that goes to, we know it's a risk. And I explain this to patients all the time. You might get a result, and Laina, thank you for showing all those different changes as how they come out in the genetic report that sometimes parents get. And sometimes it can be scary if you have not received counseling, or if you see the report ahead of time and you see all these letters and you don't know what's going on. And so that's what that means, what Laina showed. But and I remind parents, you might go and you might Google and you might see all these things, but just because you have a variant in a gene doesn't mean you're going to have every single type of symptom that is listed. And so we're going to evaluate every child, and we know that's a risk. But it doesn't give you the diagnosis. And autism is a big one. People come to see us, their child has a diagnosis of autism, and they want the genetic test to like give them the diagnosis, or they're worried about it, they don't have it yet. And we always remind them that the genetic test itself is just another piece of information that we put together, but it doesn't automatically give you the diagnosis, because even with GABA-A variants, although epilepsy and seizures are such a big part of the clinical picture, not every single child or patient will even have that. So you still have to look at the symptoms. But that was a long way to answer that. We don't know. And I think most of the GABA-A variants, you have a risk. And something I wanted to mention as well as part of the inheritance, I think GABA-A variants are a little bit different than a lot of our other disorders and what we see, because we often, unless you have a parent that's mosaic, and we can use the FLC6A1 example because that's similar, but most patients, if you have 50%, change, like the one change, that person is going to be affected. And then they have a 50% chance of passing it on. And so if the parents are not affected, almost always it's going to be a new change in the child, unless you have a mosaic parent and they might not be affected at all, or have some small symptoms or milder symptoms, and that's going to depend on how much, like what the dose of the mosaicism is. So like, do you only have it in a few? You may have no symptoms at all. With the GABA-A variants, that's a little different. Patients where maybe they only have fibrosis, and that's, they went on, they had families, and then 50% every time of their pregnancies are going to have a risk. The more severe changes, those are the ones where you tend to see them de novo, because they're just more severe. So the parents, they're not necessarily having children later on in life. And the other tricky part is that even if you have the same variant, that you may present differently. And to your question about the environmental influences, we really don't understand the environmental picture yet. We do know also that there's gene interactions that we don't understand. So we have a lot to learn, but I did want to clarify that because they can be tricky. You can have new variants, but particularly in GABA-A variants, you're going to see a lot more that are inherited from parents, which is more unusual in our epilepsy genes. And then you can have the mosaics and the homozygous, meaning the two changes. That is extremely rare, and almost always you're only going to see that in what we call consanguineous families, meaning that people that are related to each other are marrying. Other than that, it's extremely, extremely rare. It can still happen, of course, but that's going to be very rare.
I wanted to ask you about the mosaicism, because that's what Eleanor has. And I want to piggyback off another question regarding Samuel's question for autism. So in the mosaicism, what happened in order for her to receive a mosaic deletion? Do we know where along the timeline it happened, or approximately, and how, why?
Yeah, that's a great question. So we know that it happened sometime after the egg and sperm came together. But that's all we know. It was probably in the first couple times that it splits. And then the body then goes from there. It has one set of cells that don't have that deletion in this case, and another set that did have it. And they keep dividing and making more cells. And so depending on where those cells end up in the body, some parts will have it and some parts won't. So there's no particular reason why that would happen. It happens really all the time in our bodies where random changes come up. Usually our body is either able to just deal with it. It doesn't actually make any difference, and we just sort of carry on. Or sometimes those cells, it's a really big mistake, and so that cell dies, and then other cells will replace it. So this happens when there's a change that causes a problem, but not such a big problem that the cell can't survive. So we don't really, this is just a part of human DNA that these changes come up as cells divide, but it's not necessarily caused by any environmental thing or anything that someone did or didn't do that can cause that. It just randomly happens.
Because my thought was Eleanor was an ICSI baby. So I thought maybe somewhere along the line, because it happened, during the initial split, that, a table could have moved or something could have happened during that time, but you're saying that we don't know.
Yeah, and that's a good question too. We do know those types of procedures can introduce a risk for one particular type of disorder, but not deletions like this. So this deletion would probably happen completely randomly. It's a very small increased risk for this very particular set of conditions. But that's a great question. I know certainly people like wonder of like, well, if we, had a different procedure, would this have been different? And in this case, probably not. I don't think that would have made any difference.
Okay, and then going back to Samuel's question about autism, if a parent is wondering whether their child has autism, what is the first step that they can take towards a diagnosis? Or any kind of like signs that autism could play a role in that child's life?
Yeah, that's a very good question. It's, I can speak to Pennsylvania, but I suspect that most states have the same approach, which is starting around 18 months of age, because sooner than that, as far as we can tell now, it's too soon for clinicians to diagnose. But at 18 months of age, there are screening questionnaires in your pediatrician's office. In Pennsylvania, we use something called the MCHAT. They're easy questions, and they tend to get at autism is a disorder of language and social interactions. That's the simplest way I think of it. And then there can be many other symptoms that come with it. But those screening questions have to do with speech delay, and then the way that they interact with others and play and their families. And so that's usually the first step that if you're worried, your pediatrician can screen. And again, usually it's automatic, but if they haven't, you can start that conversation. That's going to be the fastest way. And things that might point you or concern you about autism, could be speech delay, but also not wanting to play with others in ways that are expected for age. Like on an 18-month-old, I wouldn't expect them to want to go and play a board game, but they might want to grab a toy, and then if the toy is interesting to them, they probably would want to show it to the parent. And so if you have a child that really does not show any interest in showing to known caregivers like interesting things that they find, that's a concern. Other things might be they're not developing speech and now they're using you almost as a tool, like they'll grab your hand to get stuff, or they'll just take you to what they want. And then there's such a broad spectrum, but things, you start getting into rigidity, meaning that things have to be a certain way, or you can't change routines, sensitivity to textures, environments. And, like I said, it's so broad because if you've ever had a toddler, right, like they may decide that they don't like crunchy stuff one day and then the next day. So you got to put it all together. But particularly if there's speech delay, that's something that should get us looking a little bit more and looking for these other signs. But your pediatrician would be step one. And then depending on where you live, whether you see a neurologist, a psychologist, or a developmental pediatrician or a psychiatrist, and sometimes even general pediatricians get trained. You would complete certain questionnaires, and that's how you get the diagnosis. A genetic diagnosis does not give you a diagnosis of autism. It just puts that autism as a symptom you could have, and then you would absolutely want to screen at that point.
We're actually working on getting our GABA-A variants into NORD. And it's a long road, but they have to be associated with autism. So one of the projects that we're working on is trying to figure out, the prevalence within our community and which genes are associated, because I have a list, but we want to understand the prevalence. You mentioned like screening tool parents could use just so we could have like a preliminary understanding of the numbers within our community.
MCHAT, which is on the Autism Speaks website. And I think you can go online, actually. I'm going to put it in the chat. And it looks like you can, and it's a screen your child, and you can actually, as you go, answer questions. Like the first question, just to give you an idea, is if you point at something across the room, does your child look at it? And then
that is exactly what we're looking for.
Yeah, so if you go on there, you just click on that, and you can screen your own child. But I would say MCHAT is screening tool. It's not a diagnosis.
Yes,
For,
absolutely.
for purposes of counting who has a diagnosis of autism, I would definitely recommend that you use, done by a clinician.
Clinician, absolutely, absolutely. But this would kind of like be the first step for us.
Yeah. So thanks for asking, because I didn't realize, and that's on the Autism Speaks website, that you could like easily just click on that and screen yourself.
Yeah, I'll put that link on our website. So this is why these conversations are so fruitful.
Great.
You mentioned that you have a multidisciplinary clinic, and also that certain drugs have different reactions. And the more people we speak to within the GABA-A variant mutation community, the people who are working on, getting us from lab to clinic transitional treatments, they're really honing in on grouping gain of function and loss of function. And so we're right now understanding how important that is with the types of drugs the compounds that we're giving our children. So thank you for mentioning that. And we're compiling this list of all of the gene mutations and their variants so that we can have a better understanding. We're at 97 patients.
Wow, that's a lot.
Yeah. The list is 300. Reiki Moeller has a list of 900 in Denmark. We don't know how many of those people are still with us, but we have definitely registered that many people. So it's really exciting, and it grows every day. I also wanted to mention how I'm grateful that you're bringing awareness to outcome measures, because we have that clinical trial going on right now in New York with Ravicti, phenylbutyrate, Dr. Greenspan in Cornell. And this is a common thing I'm also hearing, is that people are focused on seizures because it's an easy outcome measure. But in GABA-A variants, there's so many other things that are important to us, like speech and movement. My daughter has movement disorders, like these tremors that don't come up on an EEG as a seizure. And so there's so many of those factors. And what we're doing is we're onboarding our community to Matrix, that has the validated surveys, and to Citizen, that is compiling medical records. And so we're hoping that we'll have a better understanding through like natural history and have different outcome measures for future clinical trials. Because as we're trying to enroll patients into the clinical trials, some of our patients no longer have seizures.
Yes, and that's an issue. And I think something that I really like about our Engine clinic is that we use standardized forms for our intake the doctor has to use them, but I think the vast majority of us we do use them. And so it makes it really nice when we are mining, and sometimes the people mining for data are not clinicians, so it makes it tricky, and they can basically systematically use the same words we're all using, and it includes sections like other, not just you have a seizure section, but then you have a section on associated symptoms, and they split them into developmental, behavioral, cognitive, physical. And so physical would be like feeding impairment with G-tubing kind of thing. And so this is something that we actually work, Zach Greenspan is also in the same electronic learning health system, and we are all working to standardize our systems, because if you have ever actually done any chart review, it could be such a nightmare to find the shifts. And so in this way, this is not only standardizing the language that we use, it makes us screen for the other symptoms, and then they're recorded in a way that are easy to find by med students or postdocs or PhD students that maybe are not clinicians or things like that. So it's something that I really like about our clinic that I haven't seen a lot of other places do as well.
Things are changing, and we're hoping that things will change for GABA. Yeah. Thank you so much, Laina. Thank you so much, Pam, for joining us. It was wonderful to chat with you, and you really went through everything so clearly. So we are so grateful for that. And we look forward to talking to you soon.
Great. Thank you so much for having us.